Yeah, we can.
Okay.
Yes.
So thanks again, Madam Vladimir, for putting this program together. And let's see if we can be at the same level than yesterday, which was a fantastic journey. And I should start with the anatomy of the insula. And as usual, I like to share some cases with you in order to see how we can optimize anatomical knowledge in order to perform our cases. So this is a classic slide which shows that regarding gliomas, it has been quite proven that maximizing our resection, minimizing the morbidity is the gold standard for the time being. So that's why anatomical understanding, specifically in this curious region, is extremely important. So here I'm sharing with you 3 different cases in which you can see 3 different insular tumors. The first one is a purely insular tumor located in the insula. Second one is a tumor located in the superior temporal gyrus and also invading the insula. And the last one is that classic case in which we can see how the tumor is spreading along the operculi, fronto-orbitary, even the gyrus rectus, and the temporomesial areas, moreover the insula. So as you can see, we have different scenarios, and different tumors deserve different surgical planning. And for that, we should understand the deep anatomy of the insula, which is located, as you can see, in the depth of the sylvian fissure. So the insula is completely covered by these 3 operculi, the orbitofrontal, the frontoparietal, and the temporal operculum. So these lips are completely hiding and covering the insular lobe. If we uncover and split the sylvian fissure, we can identify 3 different sulci, semicircular or peri-insular. So we have the anterior peri-insular, superior peri-insular, and inferior peri-insular sulci. In between all of them, we have the insular apex, which is this part of the insula which gives this triangular or pyramidal shape to the insula. So this is the tip, the most superficial part of the insula, which is most likely to be located at the level of the pars triangularis and the anterior sylvian point. We can also easily identify the central sulcus of the insula dividing an anterior and a posterior lobe, and this central sulcus is continuous with the central sulcus of the telencephalic hemisphere. Let's go to the real anatomy, which most likely is like this. This is a coronal cut in which you can see how the frontoorbital, frontoparietal, and temporal operculi are covering this depth anatomy of the insula. So you can see how the superior part of the insula is facing the frontoparietal operculum, while the inferior part of the insula is directly facing the subopercular anatomy of the temporal lobe. So if we split again the fissure, we can see the important relationships in between the short and long gyri of the insula together with the subopercular parts. So an important one in the temporal operculum is the so-called anterior and posterior transverse gyri of Heschel, which is the primary auditory area. Why the insula is hidden in the depth of the sylvian fissure? That's because of this capricious procedure which is happening during the embryology, during the embryological development. As you can see, the telencephalic flexure is the responsible of this deep location of the insula. If we have a look at the different stages of the evolution during the embryogenesis, we can see and easily understand how this part in between the frontal and temporal rudiments, where the green asterisk is located, is finally gonna become the insula. So this ventral aspect of the telencephalic vesicles will give rise to the insula. And as you can see, it's directly connected and related to the frontal and temporal lobes. And this is of extreme importance in order to understand how these tumors are growing. This is a different study in which brain MRI was done in different weeks of the gestational procedure. So you can see how progressively the insula is getting hidden in between the frontal, temporal, and parietal lobules. So let's come back again to our 3 cases so we can see that this anatomical understanding will let us understanding more easily how this tumor is invading not only the insula, but also the fronto-orbitary gyri and temporomesial areas. This one is invading the insula and the neocortex of the temporal lobe, and the last one is a purely insular tumor. But moreover, we have to understand the deep white matter fiber tracts related to the insula. And these ones, the shape of these ones is also influenced by the embryological development. So we can understand finally, if we have a look at the different stages of the evolution of the embryo, how these fibers are gonna finally become in ventral and dorsal, because the insula is gonna push mainly the association fibers ventrally, where we mainly have the IFOF and the uncinate fascicle, and dorsally, where we will mainly find the arcuate and the superior longitudinal fascicle. So this is the capricious anatomy of these white matter fiber tracts, which is quite influenced again by this telencephalic flexure. Let's see how we can dissect some of these fibers in our brains. So this is a classic cut, coronal cut of a given gyri and sulci, in which we can see the descending and ascending projection fibers located in the center of this subcortical unit. And then as we move laterally or externally, we can see the commissural fibers, long association, and the most superficial ones in the depth of the sulcus is the short association fibers. So if we split these ones and remove and scrape away the cortex, we will uncover the U fibers as we can see here. Next step of the dissection, generally I do it at the level of the posterior aspect of the middle temporal gyrus. So we perform a cut in the center of the gyrus. So this means that we will probably be uncovering the long association fibers. And with a wooden spatula, we can push these long association fibers upwards, and we will uncover the arcuate fascicle and the vertical compartment of the superior longitudinal fasciculus. As you can see, the insula is still covered, but we have cut here the fronto-orbitary and frontoparietal operculum so as to see the close relationship in between this dorsal stream and the posterior aspect of the insula. And here we do have the transverse gyrus of Heschel directly related with the posterior insular point and the long gyri of the insula. If we cut this temporal operculum, we will finally uncover the three peri-insular sulci, anterior, superior, and inferior, with the apex of the insula. And this is the so-called posterior insular point, the junction of the superior and inferior peri-insular sulci. And this is the so-called anterior peri-insular point, where the superior and anterior peri-insular sulci are joining together. The last part of the pyramid is the so-called limen insula, where the inferior and anterior peri-insular sulci are joining together. Let's have a look at the fibers which are underlying this insular cortex. So from lateral to medial, we will start removing the insular cortex, extreme capsule, which is indeed the EU fibers of the insula. So these fibers of the extreme capsule are connecting the subopercular regions of the frontal and temporal lobes together with the subcortical region of the insula, extreme capsule. If we keep going, we will see the claustrum, which is this very thin layer of gray matter, external capsule, lateral basal ganglia given by the putamen, internal capsule, and finally, how the internal and external capsules are joining together in the tip, superior part of the putamen, and joining the corona radiata. Finally, we will have the caudate nucleus right there. Let me show you this video, which was edited by one of our previous fellows, Dr. Pilar from Valencia, in which she's removing the cortex of the insula, uncovering the first layer of fiber tracts, the extreme capsule, which are connecting, again, the subopercular part of the operculi together with the subcortical part of the insula. Removing this extreme capsule will lead us to uncover the claustrum ventrally and the external capsule dorsally, as we will see right now. So this is the picture we will have with the claustrum and the external capsule. Now we are creating some artificial windows, removing parts of these radiations of the external capsule so as to uncover the next layer of tissue, which is gray matter. Indeed, this is the lateral aspect of the putamen. This external capsule looks like very thin, but indeed is very strong, and in most of the insular tumors, this is our medial limit, just lateral to the putamen. So with this dissection, you can see how we are exposing the ventral stream with the uncinate and IFOF, and the dorsal stream where the arcuate fascicle is located. And this always reminds me to the sun. I live near the beach, so always I try to identify the IFOF as the horizon layer in the sea, the claustrum as the sun itself, and the radiations of the sun, which are represented by the external capsule. Let's move a little bit deeper. And if we remove part of the internal capsule, we will uncover the next layer, which is given by the caudate nucleus. A very important part of this dissection is to realize that all these fibers are really close to each other in this point, the posterior insular point, where the external and internal capsules are joining together at the level of the arcuate fascicle, and mainly these are descending fibers, the corticospinal fiber tract. So this anatomical region is very, very close to the posterior limb of the internal capsule, where the motor fibers, very, very relevant motor fibers, are located. And also pay attention at the IFOF and uncinate relative locations. Let's go to one of these cases I wanted to share with you in order to try to optimize the surgical planning based on the anatomy. And this is a tumor which is located mainly, as you can see, in the posterior insular lobe, partially invading the anterior, because here we can see the central sulcus of the insula. So this is a purely insular tumor which is not invading the operculi and is mainly located just lateral to the putamen. So that's one of our limits. We should go transsylvian, we should go transopercular. I don't think there is a need to discuss this, but transsylvian is going to offer us an anatomical preservation philosophy, which means staying within the tumor, while the transopercular one is going to mean removing some non-functional tissue towards a functional resection. But I don't think there is a need to discuss this, because those tumors which are mainly insular, I think it's much more anatomical to dissect the sylvian fissure, and those ones which are invading the operculi, we can go through the operculi itself as the tumor is invading them. So in this case, as the tumor is purely located in the insula and the operculi surrounding this posterior aspect of the insula is highly eloquent in the left side, we decided to go transsylvian. For that, it's very important to understand the venous anatomy of the sylvian veins. So in this case, we were working in the temporal side of the fissure, and we don't need to do a wide exposure, wide opening of the sylvian fissure. We can go to the posterior aspect, slightly split this part, and then we can protect with some cottonoids the frontal and temporal operculi, and we are directly facing now the tumor. So we start a central debulking, and once the central debulking is done, we go subpially in order to identify the superior and inferior perinsular sulci. And finally, in the depth, in this case, we can see this gray matter, which was unintentional, but that's the lateral aspect of the putamen. So in this case, we expose the most lateral part of the putamen, which indeed is the medial limit of our tumor resection. As you can see right here, this is the external capsule, this white tissue, and this is the lateral aspect of the putamen. Let's go to a different one, and this is mainly a purely insular tumor. So we can identify that although the operculi are quite compressed, they are completely free of tumor. So the frontoparietal, frontoorbital operculi are pushed upwards, and the temporal neocortex is pushed downwards and laterally. The medial limit, again, will be given by the external capsule. And if we pay attention at the sagittal cut, we can see in the right side and left side how this tumor is mainly located in the anterior lobe of the insula, as the posterior part is quite free of tumor. This is a long gyri. So the tumor is mainly located in this region here, and our medial aspect will be again the lateral aspect of the putamen. But pay attention to this point, posterior insular point, where the corticospinal tract is very close to the tumor itself. So that's why we need to understand the fiber tracts, and here we do have in yellow the arcuate fascicle, and probably the most important one in this case, which is in green, the corticospinal tract. So this area we should be very, very awake in order to try to preserve the corticospinal fiber tract. So we can have a look at the tractography in the coronal cut. So here we have the arcuate fascicle, the sagittal stratum, which will be discussed later on by Professor Igor Maldonado, and in green here we have the corticospinal fiber tract. So which is the main philosophy of the transsylvian approach for these purely insular tumors? First of all, the tumor itself has splitted partially the sylvian fissure. So we are going to be very, very close to the tumor itself. Secondly, what we will do once we expose the tumor will be a huge central debulking in order to try to then expose the perinsular sulci. So this is the intraop picture, temporal lobe, frontal lobe. We will start checking the depth of the tumor itself, which is quite superficial, looking for the perinsular sulci. And now we start with high magnification to split the fissure in order to uncover the most lateral part of this insular tumor. Moving anteriorly to the vallecula, we can see how the tumor is arising there, just in close contact with the sylvian veins, as you can see here. So now it's the moment to start protecting the operculi and to perform the decompression internal debulking. So we are moving peripherally to the superior and perinsular sulci, and in this case we were very lucky because the main branches of the MCA were pushed downwards. Some relevant vessels are always protected in our center with this spongostan and some nimodipine we are using, and these are the superior and inferior trunks of the MCA which are pushed downwards. As we are moving posteriorly, what we are doing, we start our subcortical stimulation in order to look for the corticospinal tract, and this is the point in which the corticospinal tract was responding under 3 to 5 milliamps, so that's why we stop the resection in that posterior insular point right there. We had response, so we stopped the surgery at that moment. So this is our anatomy. The left side, we are dealing with these MCA branches, which in our case were pushed downwards, and we were protecting this central artery, which is very important, and it's irrigating finally the central lobule. So this is the post-op MRI, and as you can see, we can highlight again our anatomy: anterior, inferior, superior perinsular sulci. This is the lateral aspect of the putamen, and you can see a remnant of this tumor in what I call the V of Vladimir Venes, because he's always telling me that it's much better to leave this small remnant than preventing the patient from a terrible deficit. And this is the last case. This is a curious one because this is an opercular tumor. As you can see, he was operated 3 times before I met him, and it was always a low-grade glioma, which was located in this scary area in the right side of the hemisphere, invading partially the precentral and subcentral aspects of the central lobe, and also invading the extreme capsule, as you can see in the insula here. So this tumor is going to the subcortical aspect of the insula through the U fibers of the insula, which are the ones I'm showing you here, the extreme capsule. So in this case, we wanted to make sure that there was no function in the location of the precentral gyrus, where the tumor was mainly located, but unfortunately, we found some function in this tumor area, number 2, which is represented here in this 3D representation, and we decided not to touch that region. So this is negative responses in white, and we were covering the part with the response, positive response for motor function. Now we are removing the operculum, so this is obviously a transopercular approach, and now we are uncovering the posterior-superior aspect of the insula right there with the MCA branches. Now we have started to stimulate subcortically, and here we can see how these vessels, the MCA branches, superior and inferior trunks, are located inferiorly. I'm stimulating at the same time than my resection, and once we are finding some motor response, we stop surgery and we protect that region. So this is how we are extending this functional resection, not anatomical, but functional. And finally, we checked again that the response on number 2, where we are expecting to have some tumor remnant, is quite positive for motor function. So that's why we stop surgery. We are always using, as you can see, direct control with this flat electrode on the precentral gyrus. We are checking the subcortical areas also, and in some cases, in case we have some doubts, we can use the ICG in order to check that both vessels of the MCA are working properly and the small feeders on the precentral gyrus are...
2 minutes, Pablo.
Thank you, Vladimir. I'm just ready to finish. So this is the post-op in which we can see that remnant in the posterior-superior aspect, and it was finally low-grade glioma. And this is the last one. This is very special because it's invading temporomesial regions. It's invading the amygdala and the head of the hippocampus, fronto-orbitary gyri, and also the neocortex on the temporal lobe, not only the anterior aspect of the insula. So this tumor is located mainly in those areas, and in this case, the uncinate fascicle is the main pathway in order to facilitate the growing of this anterior insular lobe tumor towards the fronto-orbitary and temporomesial regions. So this is the transopercular approach. This is the philosophy. So we are using the fronto-orbitary operculum in order to reach these areas. Something important, once we remove the temporal pole, is to approach this area, the amygdala and the head of the hippocampus, trying to respect the optic radiations, which are located just above the head of the hippocampus. And we are using corticospinal tract continuous monitoring, N20 wave inversion, and then we are locating our electrode on the precentral gyrus. So we start in this case removing the temporal operculi after removing and releasing some CSF. Sometimes I like to split the anterior aspect of the sylvian fissure in order to gain anatomical orientation, and then we do our transtemporal resection. So we are moving to the pole, temporomesial pole. Now we are opening the anterior aspect of the temporal horn, so the optic radiations Meyer loop are expected to be upwards. Now we are removing the amygdala and head of the hippocampus. So this is the tentorial incisura with P1 and P2 branches. And this is the posterior aspect and inferior of the insula. So now I'm doing the subinsular removal through the temporal operculi. As we have not enough control through the temporal window, we now go transfrontal through the transpars orbitalis. And now we are gonna try to connect both windows in the subinsular aspect. So this is the philosophy, sorry, of this transopercular approach. With this approach, we can remove the inferior aspect of the insula through the temporal window, superior part of the insula through the transfrontal window, and finally, we will try to deal with the most posterior part of the insula itself. In this case, we saw a small infarct due to a damage of one of these lenticulostriate arteries, which are also very relevant, and we should be aware of them. So just to conclude, again, and as always, I like to highlight how important it is to understand the phylogenetic, and in this case, the embryological development of the human brain, understanding how the tumors are growing through the vessels and through the white matter fiber tracts, understanding the cortex, sulci, and gyri, doing as much dissections as you can in order to understand these 3D anatomical relationships, and finally try to take advantage of the interoperative neuromonitoring and new technologies. Thank you very much.
Pablo, thank you very much. It was excellent as always. There are no questions on chat, but should someone ask you a question, feel free.
Pablo, can I ask a question about...
I have a question.
Okay, Rames, please go on.
About blood supply, having done a few insular AVMs, small ones, that the blood supply to the internal capsule is mainly deep from the lenticular striate, will be deep to the IFOF. But some insular glioma surgeon will talk about short and long perforators going through the insula to supply the internal capsule. What do you think about that? Because most of AVMs are just within the insula. They do not have extension deeply, unless maybe if they are large, they will recruit more. So what do you think about the blood supply?
So I thank you, Rames, for that question, because there is a nice paper. I had that doubt also, and there is a nice paper from Professor Touré and Yasser Hill, in which they were describing these long and short perforators. And the thing is that the long perforators of the MCA are mainly located in the anterior lobe of the insula, and they do not perforate the putamen. So they stay in the lateral basal ganglia. But as you move posteriorly, there are some long perforators from the MCA branches, which indeed are quite close to the corona radiata. And these are the dangerous ones, which are feeding the posterior part of this internal capsule. This is what I have understood. And mainly the anterior limb and genu of the internal capsule are fed by the lenticular striate, as you perfectly highlighted.
Yeah, I agree. Yeah, thank you, Pablo. Thank you.
Giovanni?
Yes, very short question. If you have to, you show us a very large insular tumor. If you have a very small insular tumor in the posterior part, are you suggesting to open the sylvian fissure, or try to go transcortical?
Thank you, Giovanni. With the small ones posteriorly located, I cannot think about a more difficult tumor than those ones. Because the lips of the operculi are highly relevant in the posterior aspect, and it's in those cases in which I try to start opening the fissure. If the venous anatomy is good for that, I try to open the fissure in the posterior third. But sometimes, due to the capricious venous anatomy, you need to split the fissure anteriorly, and it's in those cases in which it's quite difficult to reach this posterior area. So sometimes you have to work above the sylvian vein, and in the same case below the sylvian vein, depending on the venous anatomy. But generally, I try to split the fissure posteriorly.
Imad?
Thank you.
Yes, Pablo, wonderful presentation and with all these nice slides. But for the amygdala lesion, it reminds me the approach designed by Yazergil for the selective amygdalectomy going through the sylvian fissure. But you went differently. You went first from the lateral, from the temporal, and then you complemented from proximal transsylvian or subfrontal, you call it. Is this something similar what Professor Yazergil identical made, but he did not went from lateral? Do you see the advantage going only from the medial side?
Well, thank you, Imad. The main difference is that in that case, the tumor was not only in the amygdala and the hippocampus, but it was also invading these areas. So if I see the path through the tumor, I try to go through it. The selective amygdala hypocampectomy, mainly designed for epilepsy, is much more challenging procedure because you are dealing with healthy tissue in the operculi. So that's why I believe he was promoting that kind of sylvian fissure splitting and going selectively to the amygdala.
Thank you.
Okay, thank you. It was a really big pleasure to listen to you, Pablo.
Thank you.
So let me now ask